I usually begin with a ding with my blue dinger, which I can't find right now. So that formally marks the beginning of our, 97th Levitt lecture. Welcome everyone to, I don't know how many Levitts we've done. This lectureship is named in honor of Louis Levitt, who was born in 1897. Dr. Levitt became a pharmacist and then a physician by attending the Colorado School of Medicine, from which he graduated in 1927. And he practiced general practice, family medicine in the city of Denver for 40 years until 1967. When he died in 1976, he bequeathed to this Department of Family Medicine. He left an endowment for us to use for the purpose of inviting distinguished speakers to our campus to educate us and edify us and inspire us about things that were most important in the world of medicine and primary care and family medicine. And we have enjoyed the benefit of that gift ever since. I think all of you who are here today will be rewarded with an especially rich Levitt lectureship. Today, our Levitt speakers are Rebecca Etz and Kurt Stange, both of whom are well known to us on this campus and have previously done Levitts. The fantasy was that Becca and Kurt were going to do a series of Levitts, and if we could keep our wits about us, we would try to compile that into some sort of durable reminder of what they have to say in terms of reflections about primary care, the state of affairs in Colorado and this department. I'm not sure we can keep our wits about us because of COVID and other fresh hells that have visited us, but we'll just see where that goes. In any event, you will be rewarded with an extraordinary Levitt lectureship today. And let me introduce them a little bit, and then I'll turn the floor over to Becca and Kurt, after which we'll take a short break. I will make some remarks about the state of the Department of Family Medicine, where we've come from and in the last 22 years and where we are now. And then I'll turn the floor over to Myra Muramoto, who is this department's next chair, whom I am just thrilled to introduce to you and to work for my next lap around the mountain. She'll probably outlive that, but this will be a rich and rewarding morning for you. So Becca Etz is, she is the co-director of the Larry A. Green Center, which is a center that exists in the American Board of Family Medicine's portfolio of sponsorship. It's a weird kind of quasi-virtual thing. They do what they want to do. I'm not sure the board necessarily approves of all of it, but this is a center. My sense of what this center is for is to study and promulgate important and necessary things in the world of primary care and family medicine. They will tell you better than that what it is, but everything they do pops up as important on my radar. Becca is the professor of family medicine and population health at VCU, Virginia Commonwealth University, but she is a child of the universe, and she's in everybody's business. She's a conspicuous, high-profile national leader in family medicine. She's a cultural anthropologist whose areas of interest tend toward qualitative research methods and qualitative designs, primary care measures, and she was the co-developer of the person-centered primary care measure, which I consider the most advanced and best instance of how to measure whether primary care is any good or doing what it's supposed to do in particular instances or not. And she has been the inspiration and the essentially driving force behind the weekly primary care surveys that have been going on since COVID hit, which have given us an extraordinary profile into what it looks like from within the world of family medicine, general internal medicine, general pediatrics, and other primary care settings during this COVID pandemic. It's been an extraordinarily valuable and useful thing. Her work encompasses sort of bridging the gap between the business of medicine and the lived experience of people who need help from our healthcare system, from medicine, for sort of making visible, rendering visible the principles, the underlying principles and the mechanisms on which the things that are good about primary care are based, and exposing the unintended, and I have to say, damaging consequences of treating primary care like a business, and looking at the kinds of policy transformations that would be necessary in order for us to fully realize the value of primary care. So I think Becca is an indispensable, she's one of the gods in primary care who's kind of throwing boulders around and pounding stuff into shape. Kurt, on the other hand, Kurt, I've known for a long time. He's, in my opinion, the single most important researcher in the world of family medicine today. That's my opinion. Kurt may beg to differ with me, and some of you may, but that's what I think. Kurt is the co-director of the Larry Green Center, and he's a family doc. He's in the Department of Family and Community Medicine at Case Western Reserve University, where he is also in the Cancer Center, where he's in the School of Public Health, where he is in the Department of Sociology, and God only knows what other departments you're in, Kurt. You're kind of spread throughout Case Western Reserve University. I learned just recently that you are the Dorothy Jones Weatherhead Professor in that department, which makes me very happy. That's a chair that Jack Medalley, one of my heroes, held for a long time. Congratulations on that. And he spent the last 25 years doing observational and interventional research into family medicine and primary care settings and public health and community health. He's looked at how these integrate to create coherent, effective forms of care. That's enough said. I think everybody gets the idea that y'all are in my pantheon, and I think you're great, and I'm so proud and feel so privileged that you're here to talk with us. I'm going to just quietly get out of the way, put myself on mute, and let you have the floor.
Thank you, Frank. Becca, it's obvious we both think it's a high honor to be the Levitt Lecturer, but this is an even higher honor. And Becca, I was just thinking that I visited Buckingham Palace once to see the changing of the guard. And okay, it was a lot of pomp and circumstance, wasn't that meaningful. This is very meaningful to us, though. This department, you all are very important in our lives. You all have been really important to us. Frank and Larry before him, and have been really mentors to us and important to us. And Myrna, we really look forward to getting to know you and working with you and the rest of the department. So we thank you for the honor of being here, both for the Levitt Lecture and for this transitional time.
I also feel the way Kurt does. I think that every university I've been in, I've always been looking for an intellectual home because it's not quite where I am. And Denver for sure is my intellectual home. So this is just, it's really special. over the past couple of years, I have done a lot of things I never actually thought I would do. Talked to a lot of people I never actually thought I'd be talking to. Almost every achievement has been virtual, which is a very strange thing. This is probably the only one where I really feel not being there. Sort of COVID be damned, I'd be hugging everybody. So it's kind of a bummer not to be there, and I can't wait till we actually get back there. It's the pilgrimage to Denver is something that Kurt and I always do. And this is extra fun because probably the 4 most important people in my career are on the screen right now. And that would be Frank, Larry, Kurt, and yes, you, Linda. Probably the 4 most influential people in my thinking, in my shaping, and that actually always had a net behind me that made me feel brave enough to walk out on the road. So thank you so much. This is such a privilege. I'm actually going to start with sharing the screen, and then Kurt and I have this super extra special secret way of being able to communicate to each other so that yes, I won't even share it. Okay. We called this talk Where the Sidewalk Ends and the Promise of Primary Care Begins. And that's really because of where we are right now. So I'll be sharing some news that's kind of rough and tough. It's just where we are. And you all feel it more than many. I mean, the pandemic is raging in Colorado more than many states right now. And it's really easy for us to sort of, and I'm going to use this word on purpose, Frank, see this as a precipice that we're just about to fall off, right? But it doesn't have to seem that way for everybody. And in fact, that's where the name precipice comes from. Frank saw this video of these birds jumping off a precipice, but they don't get hurt when they hit the bottom. They just sort of bounce and then life continues. And that's what I think I see happening in primary care. We have this chance to look at this moment as children do, which is that it doesn't have to be seen as foreboding and an ending, even though it's scary and we are at the edge. It can be seen as a moment of hope and opportunity where we actually get to shed the constraints that have kept us locked into doing and thinking certain ways, and we can start to do and think other ways. That's the hope. And I don't think this is going to be much of a worry with this crew, but after 1.5 years of doing these virtual talks, I've started putting the punchline first, just in case people started to drift away. Like, were there 5 or 6 words I really wanted you to know before leaving mentally, as you struggle to think about not checking your email while we're doing stuff. So to captivate you, I just want to tell you that primary care does well and truly grow in the wild. And what I mean by that is during the pandemic, lots of the things that confined us and structured us were released. They may come back, I don't know, they may look different, but they were released and we were allowed to grow in the ways that our professionalism drove us. And it was a beautiful thing and it happened in really good ways. And I'm hoping that we can focus on those ways. We really learned the internal, the intrinsic motivation to be personal doctors. We saw the way that at an atomic level, personal doctors are different from other people, from other parts of the house of medicine, and they are driven to help their patients. It's a special thing, and it was of a generalist foundation, which Kurt will speak about eloquently on the next half of this presentation. So this is good stuff, but we do still have stuff to learn. We do still have moments to grow. And if you know me, I always take a chance to add in, could you please do this? So we'll get to that too. With this group, I don't think we really have to hit this a lot, but I just want to remind you that there are some really unshakable truths about primary care. And I mean by that, it doesn't really matter where you are in the country or where you are in the world. If you're primary care, you are worthy, you should be worthy of the public's trust. It's about creating a space to be safe, and to be safe to be vulnerable. And that can happen virtually, can happen on the phone or in person, but it is a space in which you feel safe to be vulnerable because well and truly at a genuine level, the wholeness of your dignity is recognized. And that's the key. Your personal doctor is someone who, regardless of what's happening in the outside world, during that moment of connection, your interests are first and yours alone. And this is the basic good that society invests in. So Frank talked about this survey that we're doing. It's really been something. I didn't really fully understand what it was going to be when we started. And we've done it a lot, and you'll have access to the slide deck, so I'm not going to go through all this stuff. But I did want to share that Colorado has had a fair presence every single time we've done this survey. We've done 32 of them now among clinicians. We've done 10 among patients. We've collected over 50,000 surveys total during the pandemic. And it's really allowed us to hear the heartbeat of primary care. It's been a very special sort of thing. When we started it, the first year and a half, it was really about being able to know what was going to happen in primary care because there was no national resource, no national office. But it was also about then being able to advocate on the behalf of primary care as for what was needed to help you all during the pandemic. The first year and a half, that's really what we did. We are now at a point where we're still doing that, but we are turning to the stories that we can tell from this data set, and they are truly, truly exceptional. There's some quiet heroicism, but there is also some everyday professionalism that I think we've lost sight of, and a relational connection that we sometimes forget. So this is a data set that gives witness to the suffering of the discipline, but also gives witness to the uncommon strength of the discipline. One of the things that I wanted to share is a general understanding, and I do it in about 4 slides, of what Colorado in particular looks like over the course of this pandemic. And a lot of people focus on money. I'm not really going to focus on money. We have plenty of people to do that. It's bad. I know. We all know that. But I want to focus on the human element. And so one of the things that I looked at is that we had one question that was really consistent throughout, which is what was the level of stress in your practice related to the pandemic on a scale of 1 to 5, with 5 being severe. And what you see here on this graph is the national is in gray. You can almost think of that as a baseline, and Colorado is in orange. And you can see that Colorado is often above what the national average is. And we know why that is, right? It's where you're located. It's the suffering of the states around you and the funneling of people to you. You actually handled that in an incredibly impressive way, really managing the cases of 5 states, not just your own. At the beginning of the pandemic, the stress level was severe or near severe for about 3/4 of you. It gradually went down, which is a really good sign. I want to pay attention to the uptick now, and we'll see later, and you can see in the qualitative comments, that uptick, so it started to climb up, it's at 40% now, has a lot to do with actually vaccine hesitancy and a growing uneasiness in the workforce after having spent so much time under pressure and now having new and added surges coming in that we feel could have been avoided, that fairness factor. In addition to that, there's a shrinking of capacity. These are 2 really important things to pay attention to. So I've really stripped it down to these 2. The first is positions we can't fill. 60% of people report they have positions they can't fill. This has been fairly constant through the pandemic, but it has gradually been growing, and it really doesn't go down very often. This is not a good sign for primary care. It is a very important sign that we need to invest in the resilience of our workforce, and that doesn't mean payment, and that doesn't mean adding to the workforce. That's stuff we need to do, but it's going to take 18 to 24 months to see any reality from that. We need to think about the people who are in the job now and how we help them right now. Because of the stress and the uncommon circumstances, we also see people retiring and quitting early. Everybody always wants to know how many, how much. We can't say. We don't have any national database that really lets us know. What I can tell you is that we have a fairly consistent run of people saying that they personally know others that have retired or quit early. When we ask the question about their own status, we usually get about a quarter of people saying that they're going to leave the profession within the next 3 years. And again, that's because they're putting the patients first. They will not leave before the pandemic is over, but once it's done, they're done. This is really very hard. That's how the practices are doing. The patients are likewise having some struggles. It looks like they're low, but I really want you to notice that the 40% mark there. Most social drivers of health have increased across the population dramatically. Financial struggle we expect, but the others have equally increased. And that's true for health in general, not just the social drivers. What you see is that many of the health indicators are above, close to or above 40%. And you can actually start to see how the social drivers are pushing those health indicators. This should signal to us that once the pandemic is over, I don't know how we decide that. I don't know when that point is, but when it happens, we've got a health crisis that will only have just begun in terms of physical health from deferred care, as well as mental health, the likes of which we've really not seen. So we will have a great deal that we will have to pay attention to. But while we know that, and the data here may give us a sense of it, there are things that we're doing that are incredibly helpful and supportive. We start with looking at what's going on in Colorado in particular. I love asking this question because I think it's really important that we understand everybody is seeing great courage in themselves and in their patients, but we often forget to look to our colleagues. And over half of people in our Colorado sample have said how much the courage in their colleagues has motivated them. How has it done that? Well, one of the things that's caused people to notice that is the incredible amount of patient contacts you've paid attention to. So in 2019, the year before the pandemic, about 46% of the population saw primary care at least once. We've, as I've mentioned, been doing patient surveys. We've collected about 12,000 of them now. And what I can tell you is that every time we've collected them during the pandemic, we have about 80% of people saying they've seen primary care almost twice in the last 2 months. That's a lot of extra contact. That is a historic high marker. And I want you to think of that and remember that that's happening at the same time that we see people with open positions they can't fill and people who have chosen early retirement or who have left. It's a small, shrunken workforce that is handling the highest amount of volume that we have ever seen. We also, with that smaller workforce, are extending to do what we need to for our patient populations. So it should say Colorado, forgive me, I changed the numbers. These are Colorado numbers. 72% of you have added telehealth to increase access and capacity. And you may say, well, of course, it's the pandemic. We added telehealth. We all get it. That's not what I mean. I mean, these are people who say telehealth is here and going to continue, that they really saw it as something that expanded their ability to provide care. Almost 6 in 10 of you have been monitoring people at home, adding on services that you never had before for the express purpose of keeping people out of an already overburdened hospital systems. This is one of the invisible ways in which primary care has contributed. And almost 6 in 10 again have been adding to helping their patients with social drivers of health. So even though you're not sure about whether you can financially keep your doors open, you're making sure that your patient populations have access to all of the basic needs to monitor their health. One of the things that's made this possible and has given the resilience to clinicians that they need are relationships. Relationships are really key here. They're about the right care at the right time at the right place. And I really want to underscore this. When we ask clinicians about it, they almost don't know what to respond to us in these surveys. In an academic setting, we're used to wondering about whether relationships matters and saying relationships are foundational, but there's always a question of, does that talk match reality? When we ask everyday clinicians, these are random people across the country, about relationships, they almost don't know how to answer the question because it's just simply what they do. They provide integrated relational care. They do it in an equitable and compassionate fashion. They don't understand why somebody would ask about a given. You don't ask me if I'm using pen and paper when I need to. Of course I do. Relationships is what we do. What they don't believe or aren't always sure about is whether patients actually agree. We have a lot of cynicism right now about patients and what they feel about doctors. We are sometimes confused. And we see what claims data, which are the data we're used to paying attention to. And we think that what people purchase is actually what they prefer. And that's not true. They purchase what they can. They purchase within the world of constraints. That doesn't mean it's what they prefer. I bet every single one of you, you're all really smart people. I bet every single one of you on the screen right now has purchased something that wasn't your preference, but it's what you could get at the time. What we purchase is not necessarily what we prefer. And when we actually ask patients outright, they say, relationships are the bedrock of my care. I can ask my doctor anything, medical or not. And actually just being witnessed by them, just being seen by this person that I know is worthy of my trust makes me feel better, regardless of what else happens. It's an incredible homage to the profession that this connection is maintained. When we ask the question of patients, where do you most want to get your care? And we give them, regardless of payment, where do you most want to get your care? And we give them 8 choices, one of which is a regular doctor's office. That's the one that they choose as their first choice, about 7 times more than any other option. And some of those other options were minute clinics and retail locations like Walmart or CVS or virtual doc in a box. That may be stuff they sometimes purchase, but that's not what they think about when they think about their doctor. That's just a quick and easy way to get some care. It's different. You use telehealth to great advantage. Now, you might love telehealth, you may hate telehealth. We tend to think of it black and white, and I really wish we wouldn't. We were sort of forced into using it whole hog, but what we've learned is that there are some situations in which it's really helpful, and we're likely to use it and continue on with it. And in fact, there are some situations in which phone-based care is really good, and we might continue to use it. And some situations in which video-based care can be really helpful. One thing we know, we've asked both clinicians and patients, is that it's easier if you have a pre-existing relationship with the doc to do these things. But if you have that relationship, then many of these things are actually quite functional in a virtual environment. This could spell really good news for life after COVID and how we maintain access and connection. Where do we go from here, though, is the next important question. I'm going to provide you some insight into the gap analysis that we should be conducting. And Kurt then is going to take up on how we invest in the future. What are the strategies we should use? So this is classic disaster recovery information. When you've been hit hard by something, the first thing we need to do is understand what made us so vulnerable, because we're always going to have things that come up that are unexpected. What made us so vulnerable that we experienced unnecessary harm, and how can we counteract that for the next time? So the first thing I was curious about is, why was primary care so invisible? I look at the 2019, again, right before the pandemic, I look at the 2019 statistics and I say, okay, according to the data we have from the Robert Graham Center, 99.8% of all respiratory illness, upper respiratory, lower respiratory, or pneumonia, 185 million visits happened in primary care. In hospitals, 283,000. Let's round it up to 300,000. We'll be generous. It's still only 0.2% of respiratory illness that's seen in hospital settings. And yet What happened when a pandemic of respiratory presentation came through? 46% of adult vaccinations and 72% of child vaccinations happen in primary care settings. If you're looking at that 46% and you're saying, God, that's not even half, I want to remind you that there are dozens of places people can get vaccines. And of the dozens, 46% of them choose a single platform, primary care above others. So if primary care does that kind of work, why were policymakers so freaking blind to us? I do not understand this. This is basic information. Why, if we are 54% of all visits and a third of the workforce, why was there not even mention of the words primary care in any federal planning? Before the pandemic or after, this is a respiratory illness in which 99.8% of cases are seen in primary care and not a mention of us in planning. Relief funding, oh my God, don't get me started. If you want to know how much relief funding we got from emergency funds from the federal or state governments, here's what you need to do. You need to add up what they say they spent, and you need to subtract every specialty thing that they noticed, and every hospital that they noticed, and every health system that they noticed, and the residual that's left on and not identified as connected to somebody else is what is the most that primary care might have gotten. That's how we have to figure it out. And folks, that's about 2 or 3%. That's pathetic. And vaccines. The myth was that primary care didn't have the ability, didn't have the infrastructure to get vaccines out, that we had to go to box stores and mass vaccination settings and hire 150 people to run them, because primary care didn't have a process for getting vaccines into patient arms. They seem to have forgotten about the 46% and the 72%. They said, you know, it's all these different hundreds of thousands of locations. How could we possibly do that? We need to be organized about it. This shows how much they don't know the world of primary care. You all are doctors. You do this for a living. I ask you, how many distributors of vaccine do you think there actually are? I don't think there are thousands of places to get flu vaccine. I think there are about 6 or 7. I think that's probably as many box stores as they went to. I think we could have figured this out, but we are invisible to them. So how do we fix that? It just happens that at the same time the pandemic hit, we were able to start a NASM, a National Academies of Sciences and Engineering and Medicine report on implementing high quality primary care. This is the first study of primary care in my generation. Some people on this screen were involved in the last one, but this is the first one that we've been able to see. And it was great to have it happen at the time of the pandemic because it allowed us to highlight what was most important. There are 5 main takeaways that this report makes visible with evidence. You can point to it clearly. We are not going to adjudicate whether primary care is helpful or not, or what it is. We know these things. We've got 4 decades of information. We don't need to go over that. We present it and we move on. And we say we have 5 objectives. And the first is payment. Pay teams to care for people, not doctors to care for, to provide services. Teams to care for people, not doctors to provide services. If you are aware of any of the primary care payment reform going on right now, then you know that there are 11 states involved in primary care payment reform. And last count I had was at least 37 independent groups. If you add that all together, that's 48. I'm a qualitative person. I might have gotten my math wrong, but I think it's about 48 groups. They're all working independently and they don't share a single definition for primary care. And I don't mean the one that's in this consensus study. I mean how you operationalize it. They want to know how we recognize in claims data, what's a primary care service and who's a certification able to bill for a service. That is how deep the idea of paying doctors for services run. They can't get their heads out of it. We need to pay for teams to care for people, not doctors to care for services. We need to pay for every individual and family to have access no matter where they are. We need a workforce that's actually trained where people live, work, and play. And that's an embarrassing thing to say, frankly, to the people on the screen right now, because many of you trained in a world and gave training in a world where that happened. But we have pulled in, we have regressed to the mean of late, and we have started training people in tertiary settings far more than in community settings. We need to remember our roots. We need to remember that there's meaning in training people in the settings in which we want them to practice, where people live and work. We need digital solutions that actually serve patients, families, and teams, that are actually created to serve what we do and not to serve how we pay for it. We can learn how to pay for it, we can create that, but first in line has to be the function and purpose of primary care. And then we need meaningful accountability. Meaningful accountability we'll get to as we talk about measurement. And Kurt will go over that area. Measurement is something that tells us, what do we need to aspire to? What is it that we do that's most important? And I'm willing to bet that nobody thinks the number of boxes they tick or how many rings till the first phone call is answered has to do with that. So with that, I turn it over to my fair-haired colleague, my super twin, and Power Twins activate, and you take it away.
Thanks, Becca. One of the things that's fun about working with an anthropologist, one of the things that's important about working with Rebecca Etz, is that they ask us to not just worry so much about the answers, but to spend some energy considering what are the important questions. And the question I'd like to ask you to struggle with me for the next few minutes is, what do we do in family practice that makes a difference in the lives of individuals and families and communities? It's an important question for us because with all the things we've done, we are doing to try to improve what we do in family medicine. It's easy to get distracted by all the bells and whistles, by all the reductionist things we're doing to improve things. It's a really important question from a policy angle. And we've asked Linda to share the slides with you at the end because I want to call your attention to this horribly long URL for a paper that Will Miller wrote for the NASM report. It's hard to find, that's why we have the long URL there. But he really looked back at 40 years at the things we've done to try to improve primary care and shows how so many of the things trying to improve the parts of care have actually made the whole worse and made our ability to do what we do that makes a difference in people's lives harder and harder to do. So I'd recommend that reading to you. And I'd also like to think about, why is that question, why is what we do that makes a difference in family medicine so threatening? And I bet you've had experience of this being threatening. When people actually start to get at what we actually do, it's incredibly threatening. When a medical student goes in and asks a senior faculty member for a recommendation for residency and gets screamed at when the person tells them that she's going into family medicine. Or when we work with people on when they're talking about excellence or improving quality as narrow expertise on one thing that excludes anything that's about maybe even doing good enough on a bunch of things, that an emergent whole that's better could actually be excellence and could be quality. Shale, when we talk about who should be allowed to give the COVID vaccine in a system, or in research, when I get grant applications rejected, I usually get at least a mixed review. I usually get one person who loves it and one person who kind of likes it and one person who hates it, for whom it causes an existential crisis. And Becca and I just got a grant application to the Agency for Healthcare Research and Quality rejected, actually unscored, but it was a home run. We got all three reviewers to try to kill it. And I think it caused this existential crisis because the grant application, we were calling for a basic science of generalist practice. There's something very threatening about that. There's something very threatening that there could be basic mechanisms, complex mechanisms that interact to make a difference, that there could be a whole of what we do as generalists that's bigger than the sum of the parts. That's a very threatening idea. So when we think about those mechanisms, we typically go back to Barbara Starfield's 4 C's. And I think it's important to ask what's behind those 4 C's. And that subversive question of what we do that makes a difference. Becca asked that actually at a conference aptly named the Starfield 3 conference that she ran with a grant from ARC. And we got 70 people together in a room asking that question, looking at data that Becca had gathered from hundreds of patients, hundreds of primary care clinicians, about 90 payers, on what matters, what healthcare matters. And when people started looking at things like the 4 C's and other of these mechanisms and starting to think together about how would you measure that, it wasn't hard when they were telling stories to get a sense of what we do that matters. But when they started thinking about measures, how do you measure these things? They started panicking. And what made them panic was the idea that you would take one of these things and measure it, because these things are trade-off. These things are about balance. We see this all the time. The things we do to try to increase access for the first available appointment can potentially get in the way of continuity of care. We see these trade-offs. We need to find a balance. So there's something about this whole that's more than the sum of the parts, and that's threatening. And Barbara, before she died, called me up and said, we need to write a paper. And of course, if anything she wanted to do, I would say yes to. She said, I'm really concerned that we've started to think about primary care as just chronic disease management. And we've lost the idea that people come into us with acute care. They come into us with undifferentiated complaints. They come into us when they're really worried about something. And if you look at, and she was right, if you look now when people talk about the acute care sector, they're talking about hospitals, urgent care, emergency departments. They're not talking about us. And she was really concerned about this. And she said, let's write a paper. I said, good. And she said, why don't we get an internist, since I'm a pediatrician, you're a family physician. I said, well, you're talking about chronic care. Let's ask Ed. And she said, Ed Wagner. She said, well, you ask him, the founder of the chronic care model. So we invited them, and we had calls discussing this paper. And I spent the whole time ombudsing as they yelled at each other about this. And unfortunately, Barbara died before we got this paper written. And I don't have the courage to just write it with Ed, but maybe I'll get back to that one day. On the previous slide, the reference there is actually a really good grad student, Wyatt Benskin, looked at 35 years of NAMC's data and found that indeed the amount of chronic care visits has gone down quite a bit. The amount of visits we say are about prevention's gone up, but over the last 15 years, the number of visits for acute care has gone down. We really have made a shift. And I think we want to ask, what effect does that have on our ability to develop these relationships that are important with our patients to meet our patients' needs? Okay, now next slide, please. I want to call your attention to Johanna Lynch, whom I met when I was asked to be the examiner, one of the examiners for her dissertation. And interestingly, in Australia, she's an Australian GP. And Australia, as a number of other countries, you can't just finish your training and get a PhD in general practice, but you can get a PhD in general practice. But they don't let people do that right out of the gate. They ask you to spend 10 or 20 years going on the ground, taking care of the folks. And so Johanna did that for 2 years, focusing really on a very high needs population of people that have been traumatized in their lives. And she spends a lot of time teaching this to what she calls blood and guts bush doctors that are really working with people that have other kinds of trauma. She's going to do a workshop, a forum actually at NAPCRAG. And if you're interested in this, if you can stand another online meeting, I'd recommend the forum. I think it's going to be really interesting. But her dissertation, which is now published in a book, which I'd also recommend, has an incredibly deep understanding of what it means to practice as a generalist. But she's also pulled out this idea of sense of safety. That one of the things we do that's really helpful, that's actually healing in itself for our patients, is to help create a sense of safety in the healthcare system with us, and then to help people extend that sense of safety into other areas of our life. There are complex mechanisms we do in family medicine, primary care, that we need to surface at things so they can be understood and so they can be supported instead of beaten down by reductionistic one thing at a time ways of improving things. Sorry, I'll get off that soapbox. Next please, Becca. So those people at the Starfield 3 conference were worried about measuring one thing at a time. It might be helpful, though, to think about what emerges from these one things at a time. And I think this idea of breadth, this idea of comprehensiveness is foundational. And so let's think about what might emerge from that. One thing that having this broad focus lets us do is prioritize, focus on the most important thing in the moment. And I think all clinicians do this, but it's really different if you're looking at, if you're an ophthalmologist, what's the most important thing in the moment for this person's eye, or for this person's diabetes, or for this person's pulmonary problem, versus what's the most important thing for this person in their context. I think that's one of the magic sauces about primary care and family medicine. It's the reason that we see Starfield's work showing that systems based on primary care have healthier populations, less inequity, do that at lower cost. I think it's because we have the ability with this broad scope to focus on what's most important in the moment. And our support systems and our ways of measuring quality is blind to that. I think also one thing that emerges from that is what patients tell us is the sense of being known as an individual in my context, how healing that is, what that leads to as far as trust from being or having been trustworthy, is the ability to make hard decisions, to help people make difficult decisions at key moments in life. From that breadth comes the possibility of being a force for integration in a system that's incredibly fragmented in a fragmented society. And then there's something that gets really threatening about this as well. I think that's something that the generalist approach is really a gateway to transcendence, to seeing the unity of life. And that's tough for a lot of people to deal with. It's very threatening. I believe there's actually different levels of care. There's basic care. There's what we measure with our quality measures for prevention and acute illness. There's acute care. That's all we measure now. That's all we have ways of supporting. That's all we value for people. That's all we give people's incentives for. And in just doing that in a reductionist way, it's important to ask, what are we doing that gets in the way of integrating care? And I don't even think we really know what we mean by integrating care. Sometimes it means just bringing things together where we can find a common upstream pathway for maybe 3 or 4 illnesses and chronic diseases, and tie that in with a teachable moment with an acute complaint or for preventive service delivery or a family issue. This integration care is complex and important that we're doing. We need to understand it more. Prioritizing care. A fellow of mine did a study looking at diabetes follow-up visits in a community health center and found that an average of 28 problems come up during a simple diabetes follow-up visit. And we're always scanning for these and trying to focus on what's most important. And then somehow in doing this basic care, integrating care, prioritizing care over time, we develop the trust, the relationships. Then when the chips are down, where there's an end-of-life decision to be made, when there's a chronic illness that's not going to get better, that people have to somehow find meaning from, that we can help people through that. There's a certain way that we approach this. That's the way of the generalist. It's a way of being. It's a way of knowing. It's a way of perceiving the world. It's a way of thinking and doing. And that generalist way of being is open and humble and connected. The generalist way of knowing iterates. It goes back and forth between this broad view and the particulars. The generalist way of perceiving the world involves scanning, looking, what's the most important, then prioritizing, focusing on what Ian McWhinney called the particulars while keeping the whole in view. And then a way of thinking and doing that's about working in context, of connecting and of integrating. So I mentioned that Becca asked this subversive question about what we do that matters. And before she did these surveys of 50,000 people, she did the surveys of hundreds of patients and clinicians and a smaller number of payers, and asked what matters in healthcare. And as we were analyzing that to try to come up with the person-centered primary care measure that Frank mentioned in his introduction, we were just having an immersion. We were wallowing the data. And I asked, I learned from Becca to ask the subversive question. I said, Becca, in complexity science, there's an idea of simple rules. But sometimes the complex behavior, like the flocking of birds, can be explained by simple rules. And so I asked her, what are the simple rules for family medicine and for primary care? And we did a lot of analyses to support this, but really what's on the next slide is what she came up with pretty much off the top of her head after valuing these data. So the simple rules, there are 3 simple rules for generalist care from which all this complexity emerges. The first one of those is that when we're acting as generalists, we recognize and make sense of both problems and opportunities. So there's this scanning function. We're looking at what's going on here. We try to make sense of it. And the next thing we do is to prioritize that. We focus on what's the most important thing for this person, take into account their life stage. And we do that, we personalize care by looking at what can we do with people that might generate some healing, might promote health, or even if we can't do those, we could invest in creating a connection that's part of the relationship bank that we can draw on when the chips are done. We recognize, we prioritize, and we personalize based on what we can do that generates healing, health, or connection. And we shared this with our friend Will Miller, and he says, oh, there's 3 simple rules for specialty care too. And these are complementary. The first one of those is that they identify what's going on. So they do scan, but they identify and classify disease in their niche for management. And they interpret that through specialized knowledge, and they develop a management plan to care for the disease. Functional systems have both these simple rules working in combination and have the right balance. Our balance is way too much towards the specialty care. And this is how we're being evaluated often. This is what our quality measures evaluate. So to try to deal with that, to try to work within this measurement paradigm, this measurement culture that we're in, we developed the person-centered primary care, which is shown in the next slide here. And it's based on asking what matters. And what's really interesting about this measure is that Becca, with a little help from her friends, wrote 11 items. 11. Identified 11 domains that people said matter. A high degree of agreement between what patients and primary care clinicians say matters, a little bit less agreement on what payers say matters. And wrote a single item. And when you put these in a factor analysis, and Frank's and my mentor, Steve Zizanski, did a factor analysis, which looks at how many constructs are in this. Writing one item for these 11 items, and let's show them on the next slide, Becca. These all hang together in one factor. So this breadth that we have in family medicine, there's coherence to it. These 11 things factor analyze into one factor. They're part of the same construct. And that's a lot of what we do, I think, that makes a difference in people's lives, is we do focus on one thing at a time. But we do that by looking at the big picture and going back and forth, so that we're always putting things in context, always prioritizing things. So I think we got one more slide, and then we're opened up for a few minutes for any comments or questions that you have. And we want to particularly thank the people that are supporting this this work, because it's not the kind of thing that mainstream funders really are interested in.
So sweet that you got all choked up about it, Kurt. So we'll turn it over to the MC here and leave it open for questions.
Thanks, Robert.
Thanks. If you guys have any questions, be sure to put them in chat. I think that we probably have a small enough group. Even though it's not small at 113. If you feel the urge to speak, go ahead and take yourself off mute and speak.
I'll put it on, I'll stop sharing screen, but if we need to refer back to slides, we can.
Okay.
This way we can see each other, pretend we're in person. Everybody's shy. We
Hey,
know
Becca.
you. You don't have to be shy.
Becca, this is Shale.
Hey, Shell, how you doing?
I'm doing well, thanks. How are you?
Good.
This has been absolutely terrific. You guys are amazing, and I just love the opportunity always to learn from you. I'm actually just about to set foot into the American Public Health Association conference, which I have to say is a weird sensation to have all the public health folks, researchers, and officials from across the country convening in a state that is not in the best place for this pandemic, but that's an aside. My question is, when it comes to generalists, if there's anyone that perhaps has a generalist view similar to ours, it's the public health folks. And so I wonder if you guys have any comments about our partnerships, leveraging that mindset in such a way that can be beneficial for primary care and medicine, when there's been consistently, despite our efforts, so much divide between public health and medicine.
Sure. I'll let Kurt go first. He's done a tremendous amount of work in this area, but then I'll offer a thought.
I'm also a preventive medicine public health physician and spent 7 days a week working with our local health department early in the pandemic. And Heidi Gullett, who gave a talk, Levitt lecture, was our instant commander. One of the things I'd like to call out is that I think the things that are threatening about family practice are threatening about public health. That focus on the whole that gets in the way of the need that individuals and organizations have for control and credit for things, because you have to share those things if you're doing family practice and if you're doing public health. We've also been underinvested in for a long time, not understood for a long time, maligned now some of the pandemic. As we recover, I think we need to recognize that there are kindreds and that we are going to need recovery time. We need to invest in time for people just to recover from the trauma that they've been through. And if we can help each other out in that recovery, recognize our common values and start to develop systems, both data systems and human systems that can support what we do, that we recognize these integrating, coordinating, prioritizing functions that we do both in family practice and in public health, I think we'll be better off. So if we can somehow in our policy work say that we need to invest in both in infrastructure and in recovery time for both. That's going to be a hard sell, but I think it's going to be really, really necessary.
I would say that in the NASM report, Shale, we actually talk about this, and we talk about a need to, one of the best ways to strengthen primary care is to, at the same time, strengthen public health, strengthen behavioral health, create the financial means that allow the neighborhoods or communities of solution, in the old Folsom report language, would want. We saw during the pandemic that people actually started to create these themselves, that these connections actually grow organically in the wild when the constraints aren't put upon them. The other thing, though, I've spent a lot of the last 2 weeks in all kinds of closed door meetings with jumbo employers and CEOs of big insurance companies. And one of the things that I try to remind them, and at the same time remind us, because sometimes we need it, is that if you plan for the financing, I'm not talking about payment, but if you plan for the financing of healthcare on an annual budget, you will always have the generation of short-term solutions, and you will never actually foster connection. Connection and trust requires the investment in a relationship over time. And we're used to that. We actually enter every patient exchange investing in a relationship over time, even though we're not certain whether or not it's going to happen. Might be the first time and last time we see somebody, but that's our approach. And that's the kind of financing system we actually have. We don't have one that's based on that. It's based on different principles, and it serves to fragment the system from the very beginning. The flip side of that, of course, is that most primary care docs don't like to give anything up at all, ever. So we have lots of really good research that shows if we did everything we were supposed to do in a patient visit, the visit would take 23.5 hours. It's about time that we realize that we can't do 23.5 hours for each person, nor can we fudge it in 12 minutes. And it wouldn't matter if it was 1 hour. We can't do 23.5 and take care of the population. What are we willing to share? And it's difficult for us to imagine sharing. And part of that difficulty is because we learned this role of taking care of the whole person. And part of that is we think it means we have to be responsible for everything, but it doesn't. Things can go on without us. That maintaining connection and integrating that story is a function that we do. But the second thing that I think it hints to, and this is where you get my social science hat, is that inevitably, like since the 1600s, anytime we have a situation in which we have an explosion of communication or technology, something that blurs the boundaries of where things live, you get an instant and immediate contraction in the way people think. Their boundaries, their essence is threatened, and they need to define who they are against everybody else. That happened for us at the time that we had, speaking for myself, but I don't mind saying it, at the time that we had a caustic and acidic presidential administration that made sport of creating self-worth through the degrading of an enemy. We have absorbed that. Even if we don't do it in the same way, we've taken it in and we've acted as if, you know, primary care and physicians have turf that need to be protected against the invasion of other groups. And that somehow we can't advance without doing that. And when I talk to the AAFP, and I'll put them out there, when I talk to the AAFP, I say, God, you guys keep feeling threatened by nurse practitioners and physician assistants. You should be so lucky that they come to help you. You don't have enough people to take care of the population, and your peeps are dying, and they are under more stress than they've ever experienced in generations, plural. Take all the help you can get. So I think we have to do that blending, Shale, but I think it also means that we have to not be threatened by sharing. Kurt.
I'm just noticing, Rebecca, your answer, Rebecca, gets at a bunch of questions that David and Seth and Don have in there. And it's really, David's question is really about, he challenged us that we were focused very much on the individual. And he says, you know, care is provided in the team, whether that's in primary care or public health. And how do we do that? I think it's one of the questions that has been answered well at some micro levels. I think at the macro level, we have not answered that question. And the question needs to be answered in a way where you look at who has the relationship. Do we just do diffusion of responsibility, which is how it often feels now? Or can we say who develops the relationship with the patient? How do we develop the relationship with the community? That if we have a relationship focused with that and recognize it's not a dyadic relationship, it's a multifactorial relationship, we can start to get at this, but it's not easy. We can have general system science ways of approaching it, but it needs to be invented and reinvented at the local level. And it's really an important part of reinventing primary care and family medicine and reinventing the integration of primary care and public health.
We have a couple questions in chat. I'll start with one from Don Neese. He asks, is it possible to reconcile the tension between inpatient training demands and our roots of community, continuity, and connectedness? Or do we join GIM and become trainers of hospitalists mostly?
Do you want to go first, Kurt?
I think there's something helpful about our training to take care of really sick people in the hospital. And I think my training emphasized that as something that we would do in our practice, but that's not what it's about, that we do that as part of what we do with a larger continuity of care. Now that most family physicians aren't going to the hospital anymore, we have to rethink that. But I think one of the things, unique things that we add is that depth of experience of caring for really sick people who do end up in the hospital. So there are lots of different answers. My personal answer is I would like to see us retain that depth of experience and depth of training, but make sure we contextualize that from the beginning, that's part of a larger focus on the community and on the individual patient and family. We have the opportunity to reinvent what we mean by community-oriented primary care that includes the hospital, but isn't focused just on the hospital.
And Larry Green, our friend Larry Green, why do we think it's a good idea to segregate mental health, public health, and primary care into their own thing?
Oh, Larry, we don't. So I don't know. We tend to believe that form follows function, but that's not always true. In the world of organized medicine, form often follows territoriality and insanity. And I think that's some of what we've seen in the US. Certainly while we've always had some of those splits, the carve out, the mental health carve out created this idea that mental health reinvigorated, reified the idea that mental health was a separate thing from physical health. And even as we talk to integrate it, we still have it in our social imagination because of this carve out that we developed, that it's separate. I was actually talking to somebody, and most of the people that I'm able to see on the screen have gray hair, so I know you know what I'm talking about. But I was talking to somebody the other day about 9/11, and they were saying, oh, we learned a lot of really good lessons. TSA got so much better after 9/11. And I said, well, actually, there was no TSA before 9/11. It was created in response. But that's actually how tradition and policy works. Once something is created in there, we tend to think of it as always already there and as somehow representing a necessary given. We don't need to have the necessary given of the separation. I think it does have to do with how we pay things. I think we think public health encompasses common goods, and we see primary care or hospital physical care as something that is not a given, not a common good. It is a shift that has happened in the larger society that we need to fix. I don't have a good answer other than the reality for that one, but we can.
Very hard to do. Thank you, Kurt. Thank you, Becca. We just got started. This is an ongoing conversation. I hope you feel that way, and I hope you feel moved to continue this multi-log. We'll save the comments. We'll try to wrestle this into some kind of shape and give it back to everyone who's here. I just think, I just love you guys. I think you're speaking difficult but necessary features of what our predicament is, what our opportunities are, and what we need to do next.